Okay, so let's talk about vestibular schwannoma. Another name is acoustic neuroma, but the name vestibular schwannoma is much better. The reason is that vestibular schwannoma is a tumor, benign tumor, from cranial nerve 8, namely the vestibulocochlear nerve, that arise from the vestibular portion of the vestibulocochlear nerve, and it arises from the Schwann cells that surrounds the vestibular portion of the vestibulocochlear nerve. Now, acoustic neuroma is another synonymous, another name for this brain tumor, yet the name is not really good acoustic neuroma because it's not from the acoustic portion of the vestibulocochlear nerve, it's from the vestibular portion. And it's not a neuroma, it doesn't come from the neurons, it comes from its supporting peripheral cells, the Schwann cells. Here you can see it's Schwann cell origin. Now, vestibular schwannoma can be sporadic or can be syndromic, namely related to neurofibromatosis type 2, but most of the vestibular schwannoma are sporadic, and in sporadic case, they are unilateral. Vestibular schwannoma can be bilateral, but it's much more common if it's bilateral to be from neurofibromatosis type 2, and of course, neurofibromatosis type 2 is much more rare than sporadic cases. Neurofibromatosis 2 is a disease that is a genetic mutation in the chromosome 22 on the long arm of the chromosome 22. Anyway, it's much rarer. Now, vestibular schwannoma can grow with time, yet some of them doesn't grow and some of them even regress, but most of them grow, especially within 5 years. And you can't always predict the rate of growth, but it's estimated it's around 1 millimeter growth per year, but again, it's just an estimation. Now, MRI is the gold standard for diagnosis, MRI with gadolinium, because this lesion, this tumor enhances. And here you can see the interacoustic canal and the cerebropontine angle, the CPA. Here is the brainstem and here is the cerebellum. And here you can see a brain tumor arising from the internal auditory canal and protruding into the cerebropontine angle. This is a vestibular schwannoma. You can see that this is a T1 sequence with gadolinium, namely you can see here the enhancement of this lesion with gadolinium compared to T1 without gadolinium. You can see that the lesion is isointense or a little bit hypointense compared to the brain parenchyma, and it's much harder to see. And when you give contrast, you see it much better, a little bit heterogeneous enhancement. Yet this is not the only brain tumor that can arise from or be in the cerebropointine angle. Meningioma, for example, can be quite similar with enhancement, but sometimes there are some clues that tell you that we are talking about vestibular schwannoma or meningioma. For example, meningioma may have dual tails and involving of the bones. But anyway, this is a vestibular schwannoma. You can see that there is no here. Now, how much the tumor protrude into the cerebropointine angle, the CPA, the area between the brainstem and the cerebellum, between the pons and the cerebellum, it is called the Kuss classification. And there are grades, we will see it in a minute. And you can see this, we can measure the size of this tumor. And it's important because tumors more than 3 centimeters are considered surgical candidates and not applicable for stereotactic radiosurgery or observation. So 3 centimeters is quite a cutoff, but it's not absolute, of course. Now, the tumor can also be only intracanalicular without protruding to the CPA. So let's see the classification, and this is the Kuss grading system. You can see that the tumor can start in the internal auditory canal. This is grade 1. It's also only in the canal, so it is called intracanalicular. It's quite small. Now, when we go to the next step, this is CPA extension. It goes to the CPA, but yet not touching the brainstem. Here another one, it touches the brainstem, and in the next grade it will compress the brainstem. It's important because, of course, compressing the brainstem is a red flag. We need an intervention, a surgical approach that will take this tumor off. It will be big tumor. It can cause complication, this compression, for example, compressing the fourth ventricle and causing hydrocephalus, causing headache, and compressing lower cranial nerves. So this compression is not good for us. We need to treat it. We need to treat it more aggressively, usually using the most aggressive approach, for example, translabyrinthine approach for removing the vestibular schwannoma. So the KUS classification quite helps us understand what is the plan of the treatment. Now, the ice cream cone sign is what we saw. You can see right over here that this is looks like ice cream cone because the base is in the canal and then it is like a cone. So this is the ice cream cone. Now, what are the symptoms? Think about it. We are talking about vestibular schwannoma. It arises from the vestibular portion of the vestibulocochlear nerve. Now, a little bit surprising is that even though it comes from the vestibular portion, which is responsible for vestibular function, namely for balance, you will see that dizziness, vertigo, and things like this is not the most common presentation. The much more common presentations are hearing loss and tinnitus, ringing in the ears. Why that? Because this is a slow-growing tumor, so the brain can compensate for the vestibular loss. But this tumor growth on the vestibular portion and start to compress the cochlear portion of the vestibulocochlear nerve. This compression causes the hearing loss. You can see that almost every patient with vestibular schwannoma has some degree of hearing loss. Usually is in the high frequencies and it's sensory neural and it's asymmetry because most are unilateral. So you'll see asymmetric high frequency sensory neural hearing loss, which will cause you suspicious for a cerebropointine angle tumor that compress the cochlear portion of the vestibulocochlear nerve. Tinnitus is also quite common, so you can see that the hearing complaints are much more common. Now, what is the approach of the management? Observation is good for small tumors, especially not more than 3 centimeters. Old patients, so they are expected not to suffer too much from the tumor even if it get bigger. And for those that are quite asymptomatic, you can just do MRI every half an hour, half a year, or 12 months. And after some years, it gets longer the interval, but we won't get into it. Radiosurgery. The idea of radiosurgery is if you want to stop the growth of tumor, you can use radiosurgery, and it's applicable for quite small tumors and it can control the growth of the tumor. This is the idea if you want to stop it from growing. Now, when the tumor is big, you cannot use radiosurgery or observe, you need intervention. This is the surgery, microsurgery. There are some approach. One is the most aggressive one, which does not preserve the hearing, the translabyrinthine approach. Another one is in the middle, called the retrosigmoid approach, and the third is the middle fossa approach. Now we can see the translabyrinthine, which is the most aggressive one, for example, for compressing uh, of the brainstem, you see that there is no hearing preservation, but you will preserve facial nerve. Now, in those surgery that you think of something. One, of course, treating the tumor, treating the compression if there is, KUS grade 4, but you also think about hearing and you think about facial nerve. But you more concerned for the facial nerve more than hearing. So, or you may. So, translabyrinthine approach quite preserve the facial nerve, not the hearing, and it's good for big tumors. Retrosigmoid can preserve hearing and can be with complication of headache after the surgery. But retrosigmoid approach is just in the middle. And the last approach, which is not written here, is the middle fossa approach. The pros of the middle fossa approach is that it preserves hearing much better, but it's good for only small tumors, not big ones. And those are the main ideas for vestibular schwannoma. I wish it was quite clear. Thank you all very much, and I think that is it for now.